Imagine paying something like 1,500 pounds for a cutting-edge regenerative medical procedure. You endure a blood draw, you wait while your plasma is spun down in a centrifuge, and then you undergo a series of, well, really delicate injections.
Yeah, right into some of the absolute most sensitive tissue on your entire body.
Right. And you walk out feeling optimistic, only to completely destroy the results 24 hours later.
Just by taking a single ibuprofen to manage a little swelling. It's wild how common that is.
It really is. Welcome to the Deep Dive. Today, our mission is unpacking the highly misunderstood reality of the downtime and, the aftercare routine following the O-shot.
Because it is definitely misunderstood.
Exactly. We are looking at exactly what happens to your body post-injection and the incredibly strict and honestly often counterintuitive rules you have to follow to protect your investment.
You really have to protect it.
So let's establish the baseline based on our sources. The O-shot is a non-surgical procedure where a practitioner draws your blood, isolates the platelet-rich plasma, or PRP, and injects it directly into the clitoris and vaginal tissues.
Right, and the goal there is to improve sexual function, maybe boost natural lubrication, and treat urinary incontinence.
Yeah, so it's using your body's own biological materials to trigger this profound healing cascade.
Exactly. The goal of injecting that concentrated plasma is to stimulate multipotent stem cells right there in the pelvic region.
Multipotent stem cells.
Right.
So not the embryonic ones people always read about in the news.
No, not at all. These are adult cells that are, already living in your tissue. Think of them like blank slates that are just on standby.
Okay, yeah.
When they get the right chemical signals, they can transform into the specific types of tissue your body needs at that exact moment. So in this case, new collagen, nerve endings, and a healthy mucosal lining.
Which sounds amazing. But if you look at how clinics actually market this, the phrases lunch break procedure and zero downtime are just plastered across every single website.
Oh, everywhere. Yeah.
They paint this picture of a patient popping in at noon, getting an injection, and then hitting a 1.00 p.m. spin class without missing a beat.
Which is, well, it's a terrible idea.
Right. Looking at the clinical protocols we gathered for this deep dive, that marketing claim feels wildly disconnected from the physical reality of what your body goes through.
Yeah, zero downtime is basically a medical marketing myth. It relies on a very technical loophole.
A loophole? How so?
Well, legally and medically, zero downtime translates strictly to zero surgical downtime.
Ah, I see.
So, you don't require general anesthesia, nobody is putting a breathing tube down your throat, and you aren't going to be bedridden for a week managing complex sutures.
You can physically walk out of the clinic doors and sit at a desk.
You can, but suggesting there is zero physiological impact on your body, especially in a region as densely vascular and sensitive as the pelvis, that's simply not true.
No, of course not. And we are giving you the unfiltered practical guide today because the gap between no surgery and no impact is massive.
Massive.
Let's look at the immediate aftermath, that first 24 to 72-hour window. The zero downtime claim reminds me of going to the dentist on a Tuesday afternoon.
Oh, but that's a great comparison.
Right. Sure, I can walk out, go back to my office, and type out emails. But half my face is completely numb, I'm drooling slightly, and my jaw feels incredibly weird.
Yeah, you're functional, but you're not normal.
Exactly. So what are you actually feeling when you leave the clinic after an O-shot?
Well, the dentist comparison really captures the sensation perfectly. Because the procedure involves highly innervated areas, clinicians apply a high-strength topical numbing cream before doing any injections at all.
So you leave the building feeling nothing.
Right. The entire treated area will feel profoundly numb. That localized anesthetic creates this sort of false sense of invincibility for about 1 to 2 hours. You might feel totally fine initially.
But the clock is ticking on that numbing cream.
Oh, definitely.
Once it wears off, you aren't just dealing with the tiny needle punctures, right? You have physically introduced new volume, the liquid plasma itself, into a very tight, closed space.
Yes, and that fluid introduction changes the local tissue dynamics immediately.
So.
According to the clinical literature, the most universal sensation reported is a distinct feeling of fullness in the vaginal area that can last up to 3 days.
Wow. 3 days of that.
Yeah, the tissue has literally been plumped up with fluid. And alongside that fullness, you're navigating mild pressure, minor swelling, and often some light spotting or bleeding for the first 12 hours.
Because those micropunctures have to begin to seal themselves.
Exactly.
So if you're sitting at your desk answering those emails, you are acutely aware that a medical procedure just took place.
Oh, absolutely. The swelling typically peaks within that 24 to 72-hour window. And there's a very specific, almost bizarre physiological detail mentioned in the postoperative notes as well.
Oh, what is it?
As the numbness fully subsides and sensation begins to increase, usually between days 3 and 7, you might experience what the literature describes as tiny little pokes, or these fleeting zaps in the injected area.
Having random tiny little zaps in the pelvic region sounds simultaneously annoying and incredibly distracting.
It definitely is.
But I imagine that's actually a positive signal, right?
It is. It's the physical manifestation of the nerves and tissues waking up. The plasma is interacting with the local nervous system, initiating that regenerative response we talked about.
The zaps are good.
Very good. Those little pokes mean the treatment is engaging with your biology exactly as intended.
See, here is where human nature completely sabotages the process.
Oh, yeah. The
What?
medicine cabinet.
Exactly. If I experience swelling, a feeling of heavy fullness, and tiny nerve zaps in a highly sensitive area, my immediate instinct is to reach for the medicine cabinet. I want to bring the swelling down and soothe the discomfort.
Which is what we've all been taught to do.
Right, every time I sprain an ankle or get a headache, doctors tell me to grab an anti-inflammatory like ibuprofen or Advil. But our sources highlight that doing this after an O-shot is literally the single biggest mistake you can make.
It really is. This is the infamous NSAI check, and failing it can completely destroy the biological mechanism you just paid a premium for.
So let's break that down for the listener. Why is it so dangerous?
To understand the danger here, we have to look closely at the underlying chemistry of platelet-rich plasma. The entire success of the O-shot relies on your platelets releasing powerful molecules called growth factors.
Okay, growth factors.
Yeah, and one of the most critical ones is vascular endothelial growth factor, or VEGF.
Let me just pause you there. Vascular refers to blood vessels, right? So this specific growth factor is tasked with building a new blood supply.
Yes. It initiates angiogenesis, which is the creation of new blood vessels from pre-existing ones.
Wow.
And this is the cornerstone of the procedure, because human sexual response and natural vaginal lubrication are entirely hemodynamically driven.
Hemodynamically, meaning they rely on blood flow.
Exactly. Natural lubrication is actually blood plasma filtering through the vaginal walls.
Wait, really? I had no idea that's how that works.
Yeah. So by creating a denser, healthier network of blood vessels, you increase that filtration, engorgement, and overall sensitivity.
Okay, so increased blood flow is the mechanical driver of the actual result. The platelets are like dropping the blueprints for this new vascular network.
That's a good way to put it.
But they don't just dump these growth factors the second they are injected, do they? They need a trigger.
Think of your injected platelets like dormant seeds planted in the tissue. They contain all the genetic potential to grow this incredible new vascular network, but seeds won't germinate without water.
And what's the water in this scenario?
For platelets, that water is the body's natural inflammatory cascade. The chemical signals of inflammation are the alarm bells that tell the platelets to wake up, break open, and release the VEGF.
So taking an NSAI, a non-steroidal anti-inflammatory drug like ibuprofen, aspirin, or Voltarol, is the equivalent of spraying weed killer on those seeds.
Yes. You are actively silencing the exact alarm bell the platelets are waiting for.
That's devastating after spending all that money.
It really is. You shut down the chemical trigger entirely. Without the inflammatory cascade, the platelets remain dormant.
So the growth factors are never released.
Nope. The multipotent stem cells never get their instructions, and no new blood vessels are formed. You have quite literally canceled out the regenerative action.
Wow.
The swelling you experience isn't an annoying side effect of the healing. The swelling is the mechanism of the healing.
You are paying for the inflammation. That completely flips the script on how we are taught to manage physical discomfort. So if a listener is navigating that peak swelling phase on day 2, what is the actionable advice here? What are they actually allowed to take without ruining the procedure?
The clinical protocols are rigid on this point. For the first 7 days post-procedure, you must use paracetamol, also known as acetaminophen or codeine only.
Only those.
Yes. These specific medications are analgesics. They work by altering the brain's perception of pain, but they do not interfere with the localized inflammatory response in the tissue.
So they let the alarm bell keep ringing while making the noise a little more tolerable for you.
Perfectly said, yes.
So you absolutely have to check the labels on your painkillers.
Double check them, triple check them.
But if you cannot rely on anti-inflammatories to aggressively soothe the area, You're forced to manage the physical environment around the tissue instead.
Which brings us to the physical rules.
Right. Because if we know inflammation is the chemical trigger for healing, we have to look at how physical movement disrupts that delicate chemical environment. This brings up the reality of pelvic rest.
Oh yes, pelvic rest.
I picture the treated area right after the injections, like fresh, wet cement. You've laid down all these amazing growth factors and set the foundation. The worst thing you could do is aggressively disrupt the area before the foundation actually sets.
Exactly. The medical term for disrupting that wet cement is mechanical trauma. The tissue requires a completely stable environment to knit together.
So what does that look like in practice?
The core aftercare principles mandate strict pelvic rest. This means absolutely no sexual activity, meaning no penetrative intercourse and no vibrators.
For how long?
And no tampons either, for a strict 3 to 7 days, depending on your clinician's assessment of your tissue.
Okay, but the sources make it clear that pelvic rest extends far beyond the bedroom too. Strenuous exercise, heavy lifting, and especially cycling are strictly off limits for 48 to 72 hours.
Cycling is a big one.
I imagine cycling is banned because of the direct physical friction. You are essentially grinding down that wet cement by sitting on a hard bike saddle while moving your legs.
Yeah, the physical friction of cycling is highly destructive to the micropunctures. But intense exercise also creates a secondary problem, rapid vasodilation.
Which means?
When you engage in heavy lifting or strenuous cardio, your body forcefully pumps blood to your core and pelvic region.
But wait, didn't you just say we want new blood vessels to form eventually?
Eventually, yes. But forcing a massive, rapid surge of blood into an area that is already acutely swollen from the plasma injections that can exacerbate the swelling beyond what is therapeutic.
I see
It
that.
pushes the tissue from beneficial inflammation into traumatic inflammation.
So you have to walk a tightrope. You want enough inflammation to trigger the platelets, but not so much physical trauma that the tissue gets damaged.
Exactly. It's a delicate balance.
What about hygiene during those first 3 days? If you have localized swelling and light spotting, keeping the area clean is going to be a priority for anyone.
Hygiene is critical, but the approach must be incredibly gentle. Only showers are allowed for the first 48 to 72 hours.
No baths.
Absolutely no baths. You must avoid swimming pools and hot tubs, too.
Well, sitting in stagnant water seems like a massive bacterial risk when you have dozens of fresh micropunctures in the mucosal lining.
It is. The infection risk is significant until those injection sites fully close. You are basically introducing the flora of a bathtub or a public pool directly to vulnerable tissue.
Yikes. So just showers.
Yes. The protocol dictates washing the area with plain, lukewarm water only. No harsh soaps, no douches, no perfumed body washes.
And drying it.
When drying, you pat the area with a clean towel. No rubbing or abrasive friction whatsoever.
Just dab the area or let it air dry. Yeah, the sources highlight a highly practical, almost surprisingly simple hygiene tip for this exact phase.
Oh, the jug trick.
Yes, the jug trick. Because the mucosal tissue is sensitive and dotted with tiny needle marks, and, well, human urine is naturally acidic, peeing can cause a sharp stinging sensation during the first day or two.
It definitely can.
So the jug trick involves filling a jug with warm water and gently pouring it over the area simultaneously while you are urinating.
It's so simple, but it works so well. It relies on basic dilution. The warm water instantly dilutes the uric acid concentration before it can interact with the micropunctures and trigger the pain receptors.
That's brilliant.
It is heavily recommended by post-operative nursing teams because it prevents a lot of unnecessary distress without requiring any extra medication.
Okay, so to manage the physical swelling without NSA aids, the sources also mention cold compresses. But there are strict rules there too, right?
Yes, very strict. You have to wrap an ice pack in a clean cloth, never applying ice directly to the mucosal skin.
Right, that would cause an ice burn.
Exactly. And hold it there for no more than 10 to 15 minutes at a time.
I also saw a great mechanical trick in the notes. Simply lying down and elevating your hips on a pillow.
Oh, positional therapy.
Right. You use gravity to help the excess fluid drain away from the pelvic floor, which naturally reduces that heavy, throbbing sensation of fullness.
Exactly. You are utilizing positional therapy to assist your lymphatic system in clearing the fluid.
Okay, so wear loose cotton underwear, use the jug trick, elevate your hips, take paracetamol, and stay far away from bicycles.
Good summary.
When you look at all these highly specific rules, the natural question for you, the listener, is, how long do you have to live like this? And when does the payoff actually happen?
That's the most common question.
Because if you are putting in this much disciplined effort, you want to know when the results will show up.
Managing expectations regarding the timeline is vital because the biological remodeling takes much longer than the superficial healing.
Okay. Break it down for us.
Days 1 through 3 are your acute phase. This is the peak swelling, the strict pelvic rest, the wet cement phase. You are following the hygiene rules to the letter.
And then moving into days 4 to 7.
The acute irritation subsides. You can drop the ice packs and resume light daily activities, though high-impact exercise is still off the table.
When do you actually start noticing a difference, though?
The first real turning point emerges between weeks 2 and 3. This is when the growth factors released by the platelets begin to fully engage the multipotent stem cells.
The remodeling is underway.
Exactly. You will likely start noticing the initial wave of improvements, perhaps an increase in natural lubrication or a heightened baseline sensitivity.
But the body can't build an entirely new vascular network and lay down new collagen in just 3 weeks.
No, it can't. It is a profound metabolic undertaking. The maximum regenerative benefits, meaning the finalized formation of new blood vessels and a thicker, healthier mucosal lining, are generally reached between months 3 and 4.
So it's a marathon, not a sprint.
The timeline is absolutely a marathon, but the physiological payoff is that these newly generated tissues are yours, and the results typically sustain for 12 to 18 months before the natural aging process begins to break them down again.
Is there anything you can actively do during those 3 to 4 months to augment the final results? Can you, hack the healing process to ensure your body builds the best possible tissue?
You can absolutely augment the results by supporting your immune and metabolic systems from the inside out. Since the O-shot relies entirely on your body's own biological materials, the overall health of your body dictates the quality of the repair.
That makes sense. So what should people be doing?
Staying highly hydrated is fundamental. You cannot expect your body to build supple, well-lubricated mucosal tissue if your systemic baseline is chronically dehydrated.
Water is key. And nutrition has to play a massive role as well. Building new collagen requires specific raw materials.
Yes, your body literally cannot synthesize new collagen fibers without adequate protein and vitamin C. Ensuring your diet is rich in those building blocks during the first month is crucial.
And on the flip side, what should they avoid?
Alcohol and smoking are highly detrimental. Both substances act as vasoconstrictors, impairing blood flow to the microcapillaries.
Oh, which defeats the whole purpose.
Exactly. It actively starves the healing tissue of oxygen and delays the entire regenerative process.
There is a specific clinical note I want to pull from the sources here regarding women who seek out the O-shot specifically to treat stress urinary incontinence. The leaking that happens when you sneeze, cough, or jump.
Oh, yes. That's a huge demographic for this procedure.
What's the protocol for them?
For that specific demographic, augmenting the procedure mechanically yields incredible results. The clinical literature explicitly notes that combining the regenerative O-shot with dedicated pelvic floor physical therapy or non-invasive treatments like the chair creates a highly effective synergistic approach.
Let's break down how that chair actually works, because it sounds like science fiction to me.
It really does.
It uses high-intensity focused electromagnetic energy to stimulate the pelvic floor muscles, right?
Yes. It bypasses the brain's motor cortex.
Okay.
And it directly stimulates the motor neurons in the pelvic floor, forcing the muscles to contract at a supramaximal level.
Supramaximal, wow.
A single 28-minute session simulates the equivalent of performing over 11,000 perfect Kegel exercises.
11,000 in half an hour. That's crazy.
It creates profound neuromuscular re-education.
So you are basically treating the architecture of the pelvis from 2 completely different angles.
Exactly.
The O-shot regenerates the tissue lining and the vascular network, upgrading the hardware and the mucosal seal. Meanwhile, the physical therapy, or the chair, strengthens the muscular hammock, supporting it all from underneath.
And the combination is far more powerful than either treatment in isolation. But before we summarize the whole protocol, we must address the safety parameter.
Right, the red flags.
We have established that feeling fullness, experiencing mild swelling, and light spotting are standard physiological responses. But what are the definitive red flags?
Yeah, when do you stop waiting it out and immediately pick up the phone to call the clinic?
You are looking for any signs that the micropunctures have been breached by bacteria or that the tissue is having an abnormal vascular response.
So what does that look like?
Spreading redness that radiates beyond the immediate injection sites is a major warning sign. A systemic fever, the presence of pus, foul-smelling discharge, or heavy bleeding that resembles a menstrual flow rather than light spotting. None of these are normal.
Got it.
If you experience any of these, or if your localized pain suddenly spikes into severe territory, that warrants immediate medical intervention. Do not use an ice pack and hope it goes away.
Call the doctor immediately. Do not wait.
Exactly.
So to bring all of this together for you, when a clinic's website boldly advertises the O-shot with zero downtime, understand that they mean zero surgical downtime.
Just no surgery.
Right, you will not be bedridden, but protecting a 1,500-pound investment in your own body requires a highly disciplined week. You are committing to strict pelvic rest.
Yep.
You have to endure the physical swelling without silencing the alarm bells with NSAIDs. You have to rely on gentle hygiene, warm water jugs, and positional elevation to let your biology do the heavy lifting of rebuilding itself.
It requires immense patience and respect for your own cellular machinery. And the underlying premise of this procedure opens up a really fascinating avenue of thought regarding the future of longevity and regenerative medicine. Right now, you are drawing blood, spinning it down, and injecting it back into your body in real time. You are relying on the stem cells and platelets you have at your current age, whether that is 40, 50, or 60.
Right.
But as we age, the vitality and concentration of our growth factors naturally diminish. It makes you wonder about the near future of baseline banking.
Wait, you mean banking your blood plasma when you were younger?
Exactly. Imagine going to a clinic at age 25 when your cellular vitality is at its absolute peak. You draw your blood, extract the platelet-rich plasma, and cryogenically freeze it.
Oh, wow.
3 decades later, when you start experiencing menopausal dryness or loss of sensation, you don't use your 55-year-old plasma for an O-shot. You thaw out your 25-year-old pristine, highly reactive plasma and inject that instead.
That is incredible. You are essentially freezing time and using your younger self's biological blueprints to repair your older self's body.
It fundamentally changes the conversation from how do we manage decline to how do we time capsule our own vitality.
It really does. You protect the investment not just with careful aftercare, but by literally preserving the best possible materials for the job. Protect the investment, follow the strict chemistry rules, and let your body do exactly what it was built to do.